Well, good morning or good afternoon. Glad to be here with you, and thanks for the kind introduction, Maggie. My name's Stewart Neill. I'm a professor, an assistant professor of pathology and laboratory medicine at Emory University. Been in practice now for about 5 years, and I'm a trained neuropathologist. That's my area of specialization. Some time ago now, we at Emory started running chromosomal microarrays on most of the brain tumors that we diagnose at our institution. So I am here this morning to give you some updates on the use of broad spectrum copy number data in the clinical workup of CNS neoplasia. So let's get started. So this is a disclosure provided by Thermo Fisher Scientific, and it just basically is a standard slide, and we will move along. Speaking of standard slides, these are my disclosures, and I don't have any conflicts of interest to note. I've not been paid for this presentation, and that's all to say about that. So what are we going to be doing today? We're going to be reviewing the use of copy number data in the modern assessment of CNS neoplasia. That's a big topic. We're just going to be trying to hit some of the highlights. And in particular, we're going to be summarizing the importance of newer diagnostic paradigms, including those derived from the CIMPACT-NOW project in the workup of gliomas. So first things first, let's just review where we are with genomic data in CNS neoplasia. Basically, testing for genomic findings is necessary for the diagnosis of several CNS neoplasms, and the number of neoplasms for which it is critical is growing really by the month. These are developments driven by gains in knowledge, research, and then the resultant updated classifications. And those updated classifications really made a big step forward back in 2016 when the WHO for CNS neoplasms was updated. And in that update, it codified certain genomic abnormalities as definitional for particular diagnoses. So basically, in order to make certain diagnoses in neuropathology, you have to demonstrate certain genomic abnormalities. And I know many folks are familiar with this at this point, but I just provide some examples of some of the particular abnormalities listed below. And you'll note that some of these are mutations, some of these are copy number abnormalities, and some of these are fusion events. So in practice, basically, this change has really rocked the field of neuropathology. If you practiced at all before the current genomic era, this could be something of a shock for you. Basically, it really requires that we do genomic testing on a very large number of the tumors that we diagnose. Not only to assess for the diagnostic hallmarks in tumors that we suspect have those hallmarks, but also to exclude those hallmarks in some of the tumors that we might be just assessing histopathologically. So, for instance, if you have a tumor that has an IDH mutation, well, you are basically in the situation of assessing whether that is an oligodendroglioma or an IDH mutant astrocytoma, and you have to be able to demonstrate findings that would indicate one or the other of those, and in many cases that leads to you assessing for, say, a 1p19q co-deletion or the absence thereof. So as suggested by some of the examples on the previous slide, those hallmark abnormalities include a wide range of different types of genomic aberrations. I've already mentioned this. And so the testing for all of those changes is difficult to accomplish with a single platform. And so different laboratories have gone about this a number of different ways. And And you can probably imagine that the different approaches to this problem have varied widely from location to location. There's not necessarily a cookbook provided to you by the WHO as to how you necessarily need to assess for these abnormalities. And of course, different pathologists and different systems are going to be a little bit different as to how exactly they want to go about this as well. So I've just listed a few different mechanisms utilized by neuropathologists to assess for some of these abnormalities. Fortunately, I'm a pathologist, right? So I love immunohistochemistry. So fortunately, immunohistochemistry has played a big role in assessing for some of these diagnostic hallmarks. There is a really useful, for instance, IDH-1R132H specific immunostain that's utilized by labs all over the place. You can also assess for mutations and fusions and such by sequencing and PCR-based methods. You also see some copy number abnormalities assessed by sequencing as well. FISH is still utilized by many laboratories to assess for certain of the copy number hallmarks and some of the fusion abnormalities as well. Methylation arrays, I mentioned here, primarily, this is something that has been implemented in a few sites around the United States and has been adopted in Europe as well, particularly in Germany, as a way of assisting with the diagnosis of CNS neoplasms. Basically, there is a mechanism to allow you to generate methylation array data and then compare that to a database methylation fingerprinting system fundamentally, and compare how similar the tumor that you're looking at is to the database tumors from the past. And then microarrays is what we have run here at Emory primarily, and that some places do array CGH, and then SNP arrays and chromosomal microarrays are utilized in a variety of institutions as well. So you end up using different combinations of these based upon exactly where you are, what type of platforms you're running, so forth. And there's not necessarily an overarching mandate on behalf of any of the WHO or the professional organizations for exactly what you should do, but just trying to give you an idea of what's done. So for microarrays, we have run this now for over 6 years here at Emory, and we've tested well over 1,500 brain tumors at Emory on our chromosomal microarray system. And so we've also tested some other tumors. Hematologic malignancies are pretty commonly tested in our laboratory. Some kidney neoplasms, a fair variety of other solid tumors, but the majority have been CNS tumors. So as we've been working on our clinical specimens, generating data to assist with clinical diagnosis of tumors, we have basically watched the field grow and change substantially. The amount of knowledge that exists for the interpretation of copy number abnormalities in brain tumors today is substantially greater than when we started way back in 2014. So we continue to refine our approach, incorporating all these new data, and it's really exciting when we learn new things and we see how other folks have interpreted some of the findings that we have observed, and it's really a great era to practice in from my perspective. So the interesting thing for us at Emory has been that we actually have been in the situation of using microarray really as the sole whole genome assay that we run on our brain tumors in-house. So there's a variety of reasons for this for this situation, but we basically have not to date implemented a large NGS panel to cover a wide variety of genes implicated in CNS neoplasia. We have a small PCR-based panel that covers sort of the absolutely necessary genes to run a competent diagnostic panel for CNS neoplasia, things like IDH1 and IDH2, the major genes that you might want to know about in brain tumors. But we don't have a panel that covers a lot of mutations, and we don't have a fusion assay that covers a wide variety of brain tumor specific genes. So we've really had to rely on the microarray. We do send for methylation profiling on a few cases, but that's really just a few. We run the microarrays on just about every brain tumor we see, and we have had to basically work very hard to push that data as far as we can in order to get as much information as we can. And I kind of feel like sometimes I am, when I'm writing reports for the microarray workups that we do, I feel like sometimes I'm sort of leaving breadcrumbs for my clinical colleagues, and of course I'll call up my the colleagues in pathology who are signing out some of the histopathology reports, and kind of you oftentimes I'll be looking at the array data and thinking about, well, what could this potentially represent? A fusion, a copy number break at a certain area, or maybe you pick up an area that looks very complex, or may even chromothripsis involving a certain portion of a chromosome, and you start to think, well, maybe there's a rearrangement in this area that I just can't quite tell by the array, but I can suggest potentially looking, to confirm a rearrangement using some sort of targeted testing, either FISH or sending for fusion testing. It's been an interesting experience, and so really we rely on the array data in conjunction with the histopathology, immunohistochemistry, and this smaller mutation panel to guide us as to what maybe do we need to send out for additional testing, or suggest to the clinicians and our colleagues about some additional abnormalities that might be relevant based upon doing array testing. Say, you have an LOH involving one of the mismatch repair genes, and I've had situations where I'll suggest testing for MMR, multi-mismatch repair IHC, based upon an area of LOH, and by golly, the thing turns out to be a potentially mismatch repair deficient neoplasm. So there's a variety of things that you can find with array data if you really pore over it. And we still are excited by new things that we can find utilizing this sort of a warhorse technology. So recently in CNS neoplasia, there's been some additional developments that have basically been incorporated into our diagnostic paradigm in sort of a what I would think of as a WHO plus mechanism. So since the 2016 WHO, there was a clear agreement in the neuropathology community that the WHO only meets every few years. And we knew that based upon the pace of the development of knowledge, our 2016 WHO was going to become a little bit long in the tooth sooner than it might have in the past. And we knew that our diagnostic criteria needed to be able to change a little bit more flexibly without necessarily having to wait for the next WHO to come out in order for us to kind of keep up with the state of knowledge. And so with that in mind, there was a group formed called the CIMPACT-NOW group, which is the Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy. And so it's a mouthful, right? It's not the formal WHO, so it's not necessarily a formal WHO publication, but it's comprised of individuals who worked on the 2016 WHO and who will be working on the upcoming WHO that should be coming relatively soon. This group publishes periodic updates to propose new classification schemes and approaches, and they've been working now for about 3 years, and they've published 7 updates to date to basically suggest updates to the diagnostic paradigms suggested in the 2016 WHO that can influence practice moving forward. So with that in mind, I put together just a couple of case studies to assist in understanding some of the CIMPACT-NOW material and then some other portions of newer literature, basically just a way to highlight some of the ways that we've looked at genomic data here at Emory and used it to assist us in diagnosis of some of the more newly accepted tumor classifications. So got a couple of cases to go over, and I'll show you some pictures. It's going to be fine. We'll just go over some H&Es quickly. So our first case is this is a man in his 60s. It's an infiltrative frontoparietal mass. It's focally enhancing on MR imaging, and so this is an H&E picture here, and it shows you basically hypercellular brain tissue. And if you have a fairly broad differential diagnosis of hypercellular brain tissue, but if you look fairly closely at these cells, you'll notice that they are fairly similar from one to the next, fairly similar and fairly similarly odd looking. So to a histopathologist, this is the picture of an infiltrating glioma. These cells look glial, and they are spread through the background brain in a way that really only glial cells or infiltrating gliomas would do. So, and when you're dealing with an infiltrating glioma in a patient in this age range, you're pretty worried. You're thinking about something that could be aggressive. And so therefore, your senses are tingling. You're looking around for some of the cardinal features of a glioblastoma. And of course, the first thing you want to be looking for is mitotic activity. And I've just highlighted here a mitotic figure that we found in this tumor. But we did not find the cardinal features of glioblastoma from a histopathologic perspective. There was no necrosis, no proliferative vasculature, so we could not make the diagnosis of GBM based upon the biopsy material that was sent to us. So what we did was we ran an array on the material, and what we saw, this is a whole genome view of the array in this case. And just to summarize, first things first, I'm actually showing you the fact that this is a triploid tumor. Right? We interpreted this array in the context of a triploid background, and you'll notice that the yellow line there is sort of the new normal that we have assigned to this tumor. And in that context, we interpreted there being a whole chromosome gain of 7, whole chromosome loss of 10 in this tumor. You can't really see it because it's a little bit out of the frame, but there is an amplification of the EGFR locus on 7p. And then there's also a homozygous loss of 9p that includes the CDKN2A gene. And so with this in mind, if we were to think about what abnormalities we would typically see with a classic IDH wild-type glioblastoma, well, they would be many of the things that I just mentioned. You would look for whole chromosome gain of 7, you'd look for whole chromosome loss of 10, and you would look for an EGFR amplification. Those are things that we commonly see in IDH wild-type glioblastomas. So, in summary, basically, we've got in our tumor, the one that we're attempting to diagnose, we see many of the abnormalities that we often see in IDH wild-type GBMs, but we don't have the histopathologic findings to be able to say that. So, the verdict here is that we're dealing with something that's troublesome. We are seriously worried about this tumor, and we really think that it's a glioblastoma based upon the genomic data that we have. But so then the question comes, well, how could this be? I mean, it has to be a GBM. Look at all of the abnormalities. But how could it be that it doesn't have the histopathologic abnormalities? Well, it's a needle biopsy. Sometimes the surgeons miss the foci of necrosis. They miss the vascular proliferation. And so, you just can't quite make it there because the abnormalities just aren't present on the slides. And then the other thing is, well, maybe the tumor hasn't quite yet developed those diagnostic histopathologic features. Remember, by imaging, this was focally enhancing, and usually with something that has a bunch of necrosis and vascular proliferation, you're going to see ring enhancement. That's the classic imaging feature of a GBM. So in any event, we're sitting there, we got a problem here. We have something that we believe is a GBM, but we can't quite call it based upon what we've got on the slides. So this was a fairly common issue in neuropathology. The CIMPACT-NOW group got together and basically wondered, well, is there a way that do we feel confident enough that there are certain molecular findings that would allow us to say this is a glioblastoma, even without having some of these long-time hallmark histopathologic features? And the answer was yes. So they felt like there were certain abnormalities that we could say, okay, if you're in the cerebrum of an adult and you have an infiltrating astrocytic tumor that's IDH wild type, if you have certain abnormalities, you can basically say it's a glioblastoma. All right. This is important. It's a diagnosis that allows the entry of GBM into the diagnostic line, and it allows patients to get on to clinical trials, perhaps, because they have glioblastoma issued by the pathologist. And it really familiarizes patients and treating physicians with the expected behavior of the tumor. So the concept here is of a diffuse astrocytic glioma, IDH wild type, with molecular features of glioblastoma, WHO grade 4. So you're getting the sense here, right? This is another big mouthful, right? It's quite possible that in the near future we will just call these quote unquote molecular GBMs. But for right now, this is the diagnostic terminology that we're using. And this terminology was proposed specifically for this situation. A tumor that you have genomic evidence that it is a glioblastoma, but you don't have the histopathologic findings to issue that specific diagnosis. So basically, what were the genomic abnormalities that were proposed to satisfy this requirement? And basically, it requires finding an infiltrating glioma in the supratentorial brain of an adult with EGFR amplification or combined whole chromosome gain of 7, loss of 10, or a TERT promoter mutation. So if you were in that scenario and you can find one of those 3 abnormalities, then you can use this new diagnostic terminology. So in this case, that's what we did. We called it a diffuse astrocytic glioma, IDH wild type, with molecular features of glioblastoma, WHO grade 4. And I have to tell you, when we first issued this diagnosis, this is not totally new. It's been around for a little over a year, I believe. And when we first utilized it, our clinical teams were thinking, what are you doing? You know, this is really weird. They were somewhat alarmed by it. But of course, we've been using array data in our diagnostics for a while, so we were able to kind of assuage them. And really, since we started utilizing this diagnosis, we've used it a fair number of times, about once a month at least. We utilize it, and now we're in the situation where we really very rarely utilize the diagnosis of anaplastic astrocytoma IDH-wildtype, because frankly, most tumors that previously fell into that category show the molecular hallmarks of a glioblastoma. So this is another reminder that the generation of genomic data for cases like this is really critical. So case 2, we're dealing with a younger gentleman, and he has a mass in his temporal brain, very densely cellular, and you can see even from this low power image, there are some big cells in here that look really weird. And so on higher power, indeed, this thing is jam-packed with bad cells, and they are not showing exactly all of the features of a typical glioblastoma. They don't have a ton of fibrillarity in the background. They are showing clearly malignant features. You can see scattered around the slide those very dark structures. Some of them maybe look like little clusters of chromosomes. Well, those are mitotic figures. So there's quite a few of them here in this image. You can see one in the bottom left-hand corner that looks a little bit like a stick figure. That's an atypical mitotic figure. So this is another malignancy, something we're, again, quite worried about. We were able to confirm that it did have expression of glial markers. So it's a high-grade glioma. And we did some additional workup that suggested that it might have an ATRX mutation. We did an immunostain for ATRX, and it shows you that there's some strong immunoreactivity in some of the cells, the smaller cells in the background, but our big cells are either not showing very much reactivity at all, they're very light brown, or they're showing no immunoreactivity, they're blue. So maybe this is an indicator of an ATRX mutation, and then our p53 immunostain was very strongly positive and quite suggestive of a TP53 mutation. So usually in a younger person who has a malignant glioma that has an ATRX mutation and or a suggestive of an ATRX mutation and a TP53 mutation, first thing you think about is, well, could it be an IDH mutant tumor? And this tumor ended up not having an IDH mutation. So then we're sitting there kind of scratching our heads, wondering what could be going on. And we look at our array data, and it shows a whole chromosome gain of 7, but no loss of chromosome 10. And no whole chromosome loss of 10. And so, didn't exactly fit with the IDH wild-type GBMs that we just looked at a moment ago. It does have an amplification of 4P that includes the PDGFRA gene, and then also has a loss of 4Q. And so, taking all this together, we got a lot to think about. So, this is clearly a high-grade neoplasm. In a younger person, we have to think about an embryonal tumor, but we're thinking this is probably a glioma based upon some of our findings. It's IDH wild type in the sense that it doesn't have an IDH mutation, right? But it's not exactly the same as the IDH wild type GBMs that we looked at just previously, the classic example, and our diffuse astrocytic glioma molecular GBM, right? So doesn't have some of those cardinal hallmarks that we just talked about. However, the IHC findings, the probable TP53 mutation, the probable ATRX mutation, and the copy number data, and particularly the loss of 4Q and the amplification of PDGFRA, raises another possibility in this tumor. And there are a variety of different histone mutant tumors that have been defined, including pretty much most famously, the 2016 WHO defined the diffuse midline glioma that is characterized by a K27M mutation of the H3.3 gene, or a variety of other genes, histone genes. And so there's some of these histone mutant genes are seen along the midline in children and most commonly in adults. But we're not in the midline here. So why am I bringing this up? The reason is these are not the only CNS tumors that have been associated with histone mutations. And there are a group of tumors called the H3.3 G34 mutant tumors that, in contrast to the K27M mutant tumors, the G34 mutants are usually seen in the cerebral hemispheres. And they can show an embryonal-like histology, very densely packed tumor cells, kind of similar to what we saw in this case. They may display ATRX mutations or loss of ATRX expression. They may show TP53 mutations. They can have PDGFRA amplifications, and they may show a loss of 3Q or 4Q. And so, with that in mind, we sent this tumor for additional sequencing. And the end diagnosis was this is an IDH-wildtype glioblastoma, WHO grade 4. However, it is a specific type, a G34 mutant IDH-wildtype GBM. Okay, so this is fundamentally a different tumor type than the quote-unquote IDH-wildtype GBMs that we were speaking about in the first case. And so here, the combination of histologic and immunohistochemical and genomic data sort of pointed us in the direction of necessary additional sequencing, and allowed us to be able to make the most accurate diagnosis for this patient. And this particular histone mutant class, the G34 mutant tumors, is mentioned in the 2016 WHO, but really since that time has been better established in the literature. So we together have reviewed the use of copy number data in the modern assessment of CNS neoplasia, and we've summarized the importance of some of the newer diagnostic paradigms, including at least one of those derived from the CIMPACT-NOW project. There are quite a few others. I encourage you to read those papers if you have not already. In summary, genomic data, including copy number data, is an indispensable part of the modern diagnosis and workup of CNS neoplasia. The exact mechanisms and the platforms that would be utilized is institution and somewhat situation dependent. However, broad spectrum mechanisms are extremely useful in detecting unique and recently described entities. And I really feel like genomic information is critical, particularly broad spectrum genomic information is critical to my practice. So some acknowledgments. I really couldn't do this type of work without the tutelage and assistance of the teams in molecular pathology and oncology cytogenetics here at Emory. I, of course, rely on my colleagues in neuropathology to assist me as well, and, of course, have a lot of support from my clinical colleagues in neurosurgery, neuro-oncology, radiation oncology, and some great informatics support from our pathology IT staff. So with that, I will say thank you very much, and we'll take some questions. And if at the end of the lecture I have not had a chance to cover what you're interested in, please feel free to email me. Thank you.